Hey everybody, it's Kelly. I'm going to be playing the role of the hematologist in our case study today.
My name is Helena and I will be the registered nurse.
Hi, my name is Darielle and I am the social worker.
Okay, so today we will be discussing the patient in room 410. His name is Mark Sims. He's a 20-year-old African Canadian that was transported to ED by ambulance 5 days ago. Mark's roommate called 911 stating that Mark was unable to breathe and was crying out in pain. Upon arrival to the ED, Mark presented with extreme exhaustion, dizziness, lightheadedness, and shortness of breath. He stated that he felt like his heart was racing, his extremities were tingling, and he had frequent diarrhea that day. On examination, he was restless, he had cyanotic oral mucous membranes, was diaphoretic, reported pain out of 10, and stated that he felt the pain all over. It was noted that the patient had a 2 centimeter by 2 centimeter ulcer on the right leg, just above the ankle. Vital signs on intake were temperature of 38.1, respiratory rate of 24 and shallow, heart rate was 120 and regular, SpO2 of 89%, blood pressure was 98/54, and he had a cap refill of 4+. Peripheral pulses were weak. During triage, it was discovered that Mark also has a history of sickle cell anemia and was diagnosed when he was only 7 months old. His pain episodes are usually manageable with the prescribed medications that he has at home, but he's had 2 to 3 hospitalizations per year due to painful vaso-occlusive episodes. Mark has been taking hydroxyurea for the past 9 months. Other medications include morphine, Seneca, folic acid, and acetaminophen. He did receive treatment in the ER, which included oxygen therapy, IV bolus, dilaudid for pain, and hydroxyurea was administered. He also did CBC, chem labs, X-ray, CT, and wound culture was taken as well.
Helen, can you tell me what Mark's plan of care in the emergency department was?
Okay, so the nursing staff put together a care plan with 2 nursing diagnoses to help treat Mark during his sickle cell crisis. Let's go over the care plan. So the assessment data collected is that this is a 20-year-old African Canadian male. He's a college student that lives in a dorm and he's a social drinker. The subjective data collected is that he was complaining of exhaustion, dizziness, lightheadedness, shortness of breath. His heart was racing, he had diarrhea, and his extremities were tingling. He reported pain out of 8 out of 10 and stated, "I feel pain all over." The patient also stated, "I hate feeling like this, I can't deal with it anymore." He also has midterm exams this week. The objective data collected was that the patient appeared to be restless, he had cyanotic oral mucous membranes, he was diaphoretic, he had the 2 centimeter by 2 centimeter ulcer on the right leg just above the ankle. He has a family history of sickle cell anemia. The patient has been hospitalized 2 to 3 times per year due to painful vaso-occlusive episodes. The patient has been taking hydroxyurea for the past 9 months. And with the cool fall October weather, the heat is still off in the dorm room. The vital signs on intake, as mentioned before, temperature was 38.1, respiratory rate was 24 and shallow, heart rate was 120 and regular, SpO2 was 89%, blood pressure was 98/54, cap refill was 4+, peripheral pulses were weak. Okay, so the first diagnosis is ineffective tissue perfusion related to vaso-occlusive nature of sickling as evidenced by decreased SpO2 of 89%, tachypnea, tachycardia, weak peripheral pulses, increased cap refill of 4+, tingling in lower extremities, cyanotic mucous membranes, ulcer on lower right leg, restlessness, and pallor. The SMART goal for this diagnosis is that after 1 hour, the patient's tissue perfusion will improve and will be evidenced by increased SpO2, normal respiratory rate between 12 and 20 rests per minute, heart rate between 60 to 100 beats per minute, increased strength in peripheral pulses, decreased capillary refill, pink mucous membranes, absence of tingling in extremities, and decreased restlessness. The intervention for this is that the patient will receive O2 therapy at 5 liters per minute via nasal prongs, and oxygen saturation will increase to a normal range between 95% and 100% within 5 minutes. The rationale for this is that O2 may be administered to treat hypoxia and control sickling. The second intervention for the same SMART goal is that the patient will receive an IV bolus of 1,000 milliliters of sodium chloride or normal saline. And within 1 hour, the capillary refill will decrease to 2 seconds or less. Peripheral pulses will have a strength of +2 bilaterally, and a normal range of oxygen saturation will be measured between 95% and 100%. The second diagnosis is acute pain related to vaso-occlusion, as evidenced by the patient stating, "I feel pain all over," and the patient rating 8 out of 10 on the pain scale. The second SMART goal is the patient will report a pain level of 3 out of 10 or below 30 minutes after administering the prescribed pain medication. The intervention is that the nurse will administer the scheduled morphine to the patient as per the MAR. The rationale for this is that if the patient's pain is present most of the day, the use of PRN medications alone will lead to periods of under-medication and poor pain control and periods of excessive medication and adverse effects. After evaluation of the SMART goals and their interventions, within 5 minutes of receiving supplemental oxygen, the patient's SpO2 was reassessed and increased to 95%. After 1 hour of receiving a normal saline bolus, the patient's capillary refill had improved to less than 2 seconds, and peripheral pulses were palpable with +2 strength bilaterally. Increased SpO2 of 96%, respiratory rate of 19, heart rate of 97 beats per minute. Pink mucous membranes were noted. Absence of tingling in extremities and decreased restlessness was also noted. 30 minutes after the scheduled pain medication was administered, the patient reported a pain rating of 2 out of 10. Once stabilized, Mark was transferred over to the medicine floor.
All right, let's go over Mark's lab results. So first we're looking at his white blood cells. 16.5 was the result. Normal is 4.5 to 11. This indicates he is a candidate for an infection, stress, or inflammation. His hemoglobin is 59, indicating low red blood cells, which is also a reflection of anemia. A regular normal range is 120 to 180. Bilirubin is 1.8. Normal is 0.1 to 1.2 milligrams per DL. This is looking for liver or bile duct dysfunction. The ABGs, we're looking at pH, which was 7.25. His oxygen, 89%. And bicarbonate was 24 milliequivalent per liter. Normal range for pH is 7.38 to 7.42. Oxygen saturation generally is 94 to 100%, and bicarb usually 22 to 28. We're looking for indicators for pulmonary crisis, the severity of his pulmonary crisis or potential pulmonary crisis. Next, we're going to look at the CPK, which his result was 45 MCQ per liter. Normal is 10 to 120. This measures the levels of the enzymes in your bloodstream. We're looking for injuries to the muscle. Next, we have his BUN. His was 4.1. Regular normal is 2.1 to 8.5. This is looking at the urea nitrogen levels. A higher level would suggest a kidney problem. His are within normal range. We're looking at electrolytes. His sodium was 131, slightly lower than the normal of 136 to 144 millimoles per liter. His potassium is 4.36 millimoles per liter, and regular normal range is 3.7 to 5.1, so his potassium is within normal range. The chloride is 103.8. And regular chloride is 96 to 106, so within normal range. We're just looking at the electrolytes in the bloodstream. The folate is 2.2, regular is 2.7 to 17 nanograms per milliliter. This measures the amount of folate that is inside the blood. His is below normal. Next, we have his reticulites. His result was 2.4%. Normal is 0.45 to 1.8%. This is indicative of blood disorders. High levels indicate anemia due to red blood cells being destroyed early. His diagnostic test, his wound culture was positive, indicating infection. His x-ray was negative. We used the x-ray to rule out pulmonary embolism, and the CT was negative, used to rule out blood clots. Helen, can you tell me about his family history, please?
Okay, so Mark is currently single and he's in school to be an electrician. He lived in a single income household with his mother and younger brother, who also has sickle cell disease. His father did pass away at the age of 35 when he was only 9 years old, due to complications of sickle cell anemia. Mark denies smoking or using any recreational drugs, but he does socially drink with his friends. At the time of this latest sickle cell crisis, he was in the middle of midterm exams. This is a very stressful time as Mark must maintain a 3.5 GPA in order to maintain his academic scholarship. He currently lives on campus in student housing. He did mention that his room is cold and the heat has not been turned on yet in the residency and usually isn't turned on until mid-November.
Okay, it appears that this is an acute exacerbation, was a result of a combination of factors, including stress from school, the infection due to the leg ulcer, and the cold temperature in his dorms. Mark has sickle cell anemia and is the most severe, which is the most severe type of sickle cell disease syndrome, in which he inherited from both his parents. He was admitted to the hospital with a sickle cell crisis. It is not the first time. I have quite a few concerns with regard to Mark and what we need to address before we can transition him back to his school dorm. First, let's look at his recurring visits with sickle cell crisis. He is at risk for organ damage, particularly the kidney, spleens, lungs, and the brain. Tissue ischemia can occur and lead to further complications. As we know, his leg ulcer was a result of decreased perfusion that developed into an infection. It is currently being treated with antibiotics with good effect. Another issue is his pain management. He was stating that his pain was being managed well, and when the medications were reconciled, they were not adequate enough to manage the pain effectively, especially during sickle cell episodes or crises. After looking at his immunization history, I have also noticed that Mark is not up to date with his immunizations for influenza. He is lacking in the Haemophilus influenza and pneumococcal vaccine. These are the particular areas that I would like to focus on. And Helen, do you have any other concerns or anybody else?
Yes, I do have a few concerns. I spoken with Mark and he mentioned to me a few times that he's tired of going through this and can't deal with it anymore. Upon further investigation, it was determined that he was talking about his frequent hospital stays, like in the treatments and how long they've been going on. He also discussed how he never really grieved his father, death due to focusing on like his own health. And I believe this affected his overall emotional state. We did discuss a few options, and then he did state that he is open to attending counseling and support groups with other patients diagnosed with sickle cell disease. And I've located a few options specifically for sickle cell patients. One being Sickle Cell Anemia Canada, the Toronto chapter, and then another one being Sickle Cell Ontario. They both offer free counseling services, both one-on-one as well as group sessions. And I reached out to Sickle Cell Anemia Canada, Toronto chapter specifically, and they said that they are willing to work with Mark, which is a good thing. And they also provide school support and trainings for like the students, the parents, the teachers, as well as the staff of the school. And this is important as I know like Mark was hospitalized during his midterm exams, which means he did miss them. And this organization stated that they would contact his school to see if they could help provide any like accommodations and support so that Mark is able to go ahead and retake his midterms. I did write a note stating that Mark was hospitalized during his midterms, but I think a note will also be very good if it came from you, doctor, like a letter just stating that he missed his midterms and asking if he can retake them.
Yes, I will be sure to provide Mark with a letter for his school by the end of the day.
Thank you so much for that. That would be very appreciative. Um, my other concern here is that Mark state he does live in the dorm and that the dorm doesn't turn the heat on until mid-November. As we are well aware, like we're well into fall and the sickle cell crisis is exacerbated by the cold. So Mark must have like a warm place to stay once he's discharged. And then with speaking with Mark about that, I did understand that he's currently on OSAP and does have some money left. And he's hopeful that that money will take him until January 2023 when his next OSAP payment is released. Now, since Mark does like not have like the extra means to purchase like extra supplies like to keep him warm this winter, and since the heat doesn't get turned on until mid-November, I have reached out to the Salvation Army just to see if they can give him like a few donations, and they did agree, which is really good, to donate like a heavy winter comforter, a heated blanket, winter gloves, hats, scarves, some long socks, and then like a few pair of thermal underclothes from the store. I also got them to put together like a food donation box from their pantry that includes things like breads and nuts and oatmeals, teas, and like also they gave him a small voucher, which is very great. And that voucher allows him to purchase like fresh fruits and vegetables from the actual store. Now these items is just to help Mark like stay warm during the winter months, and just in case like he does have like a meal plan, but just in case he doesn't want to leave his dorm to go out in the cold to go to the cafeteria to purchase things, he does have these backup items. And just in case he does need like further donations throughout the winter, I have passed along the manager's contact information from the Salvation Army on to Mark. Now, another thing that while talking to Mark, I discovered was I know that Mark's mother has been paying for most of his medications out of her pocket, and after some investigation work between me and Mark, we determined that Mark does have like a medical and dental benefits through his school, which is paid for whenever he pays his tuition. And the benefits start from September and then end in August of the next year. So as long as Mark is a student in the school, he will continue to have healthcare coverage. Now, Mark and I did contact his student administrative center, and they did help us locate Mark's health plan as well as the plan number. So now that his prescriptions can be paid directly through them, and this will help alleviate the financial pressure from his mother as well as Mark, which is a good thing. Another thing that we were talking about with the student office at his school is that they do offer other programs for him that he wasn't aware of. So they do offer a food bank where students can register 24 hours before and pick up a food hamper to help them through the month. They also have a soup program where the students can get a free bowl of soup every day from the school cafeteria, which I found to be very nice, especially during those winter months when you want to stay warm. And his school also has a medical center on campus that can administer his vaccines. I know that you said that he was missing a few. So later on today, me and Mark, I'll assist him with calling the school's medical center and setting up an appointment to see if he can get those missing vaccines done where he doesn't have to travel far, just to the school campus. Then lastly, from chatting with Mark, that me and Mark had, I also understand that that the plan was originally to get wound care at home. Now, with speaking to Mark about that, that was a concern from him because he lives in the dorm and he didn't want to really receive wound care at his home because he didn't want all of his peers and his classmates and everyone that lives in the dorm to learn about his diagnosis. And I do know just from often I find that individuals with certain medical conditions or even any medical conditions don't like receiving special treatment or special accommodations as they fear like from being visible and judged. And by visible is like everyone just staring at them and now everyone can see them because they do have this special accommodation. And so then they often like to stay invisible and remain to be treated like what they would consider a normal person, to like avoid the stares and the sympathy. So they don't really often reach out for help and accommodations. I am trying to work on Mark with that as well. But I do think that it will be best for Mark to schedule his wound care appointments at a wound care clinic. And that's just to help Mark and build his confidence. And since he doesn't want at the dorms because he doesn't want everyone to know, he did say that he is willing to travel to a wound care clinic close to his house to get those his wounds cleaned.
Those are great resources that will benefit Mark. I will send a referral letter to the wound clinic near Mark's dorm and have him scheduled there within the week from today.
Okay, in regard to Dr. Kelly's concerns, I will create a care plan for Mark and meet with him. The care plan will include patient education regarding sickle cell disease, causes of exacerbation, and preventative measures such as getting enough oxygen, avoiding strenuous activity, and avoiding high altitudes, making sure that he gets adequate fluid intake, avoiding extreme temperatures, avoiding and preventing infections, minimizing stress, ensuring immunizations are up to date. I will also review the signs and symptoms related to complications of sickle cell disease, which include acute chest syndrome. Signs and symptoms for that would be the fever, chest pain, cough, pulmonary infiltrates, and dyspnea. And it could be life-threatening. So I feel like that's important for him to know in case he is not aware of that yet. Other complications include pulmonary infarction, pulmonary embolism, and priapism, and I will include information about those as well. In regard to pain management, I will review medication changes, dosages, and side effects with Mark and ensure that he takes his medication at the scheduled time to avoid periods of unwanted pain. I have the prescription list of medications and will fax it over to the pharmacy near Mark's residency. Lastly, I will inform Mark of his follow-up appointment in 1 week at the wound clinic so that his leg ulcer can be assessed and treated as needed.
Okay, let's just review Mark's medications. He will continue to take his hydroxyurea at 1,000 milligrams PO daily, his anti-sickling drug. He will take acetaminophen, 650 milligrams TID PO. He will continue with folic acid, 1 milligram PO daily. Of course, we need that for making new red blood cells. And he will take Senecot, 1 to 2 tablets daily for constipation. I have increased Mark's morphine dosage to 30 milligrams PO QHS and have added 5 milligrams PO Q6 hours. This will manage his pain more effectively. However, Helen, please include patient education regarding the signs and symptoms of respiratory depression, such as the shallow, slow breathing while taking the morphine, and to never double dose. He has also been prescribed the same antibiotic that he has been given here for the last 5 days, flucloxacillin, 500 milligrams PO QID, and he will take it for an additional 2 days to complete the 7-day cycle. Please ensure that he understands that he must take his antibiotics for the full course.
Not a problem, Dr. Kelly. I will include that in the care plan as well.
Great. If there are no other concerns, that concludes the rounds for today.